Hi guys, and welcome to today's video. Today we will be talking about how to manage a child with an asthma exacerbation in the emergency department, as compared to our previous video when we were discussing about stable asthma management in the clinic. So we'll start off with a very typical kind of case study of a child who's wheezy and breathless. So let's have a quick look at our case. This is Mariam, a 5-year-old girl known to have asthma, who's brought into the emergency room today. She's having a 3 days history of runny nose and cough, followed by difficulty in breathing just today. Her cough is intermittent throughout the day, with particular worsening at night, which is preventing her from sleeping comfortably. So, this is an important question to ask the family, as they may not volunteer the information themselves, but it's giving you a good indication of the severity of the illness just from the history. And we can see that the cough has been getting worse over the last 3 days and associated with a whistling sound since yesterday. So we can't ask the parents, does the child have wheezing? You will get a very rare set of parents who know what wheezing exactly is, or they may attribute wheezing to some other kind of abnormal sound. So the best way is to describe what you mean and then ask them accordingly. Since midnight, she has been refusing to lie flat on her back, unable to speak in sentences, and is becoming increasingly agitated. So, these are very clear signs that it's a serious kind of exacerbation. And it's important to ask, even if the parents don't immediately give you this information by themselves. So, if we have a 5-year-old child with wheezing and difficulty in breathing, what are some of the differential diagnoses that we have? For Mariam's case, we know that she's a known case of asthma, so the top differential will be an acute exacerbation. For other kids, we may consider, and even for this patient, but slightly lower down, we will consider a lower respiratory tract infection, and they may well be concurrent, like the infection could have triggered the asthma exacerbation. It can be a foreign body aspiration if the history is appropriately going with that. So, the most common kind of history you'll get is sudden onset of a cough associated with this kind of wheezing if the child was left alone or playing with a sibling with some small toys. So, that can be an indicator. An allergic reaction, of course, very important, and we'll discuss that in a later presentation, how we diagnose anaphylaxis in children. But allergic reaction is very important because difficulty in breathing and wheezing are can be components of an anaphylactic reaction. And gastroesophageal reflux or aspiration pneumonia, these are also causes of wheezing. But for our patient and for sake of time, we have kept them at the lowest point in the differential diagnosis. So we narrow down the differential diagnosis by going through a comprehensive systematic review. So fever, mother's not sure, but she didn't feel that she's warm. The child is not eating or sleeping well since yesterday. And other than that, she's not been having any other symptoms of note, especially there has been no choking. And only a herbal cough syrup was given at home. And this is very important, especially in cases of asthma, because you would expect that this mother would have given the child some Ventolin or the rescue medication at home. But we can see here that child is quite sick and she has not received any of the appropriate medications. Her past medical history is that we know she's diagnosed with asthma, but she has recently required an ICU admission in the last month for severe status asthmaticus. So this is a huge red flag in this child's history. And once again, I'll mention that some parents don't realize it's important, or in the stress of the moment they forget to mention that this kind of thing has happened before. But if a child has required ICU admission before, this makes them very high risk and you need to manage them very, very closely as compared to just a child with a mild kind of exacerbation. Another point in the PICU admission is you need to ask if the child needed intubation or mechanical ventilation, because in asthma management, as we'll see later on, that is the absolute end of the line for interventions that you will do for the child, the thing which your avoiding the most but have to do in the worst of circumstances. So that is the intubation and ventilation. Other than the asthma, she doesn't have any health issues. And since discharge from the PICU, the parents were requested to follow in the asthma clinic, but they did not attend because they felt the child is doing fine and her asthma is cured. So this is another huge issue which you need to make sure you ask the parents if the patient has been taking their asthma medications and following up with a doctor regularly. Because chances are quite high that if the child is having regular exacerbations, either they are not taking the medications or they are taking them incorrectly with an inappropriate dose or inappropriate technique. So this needs to be confirmed with the parents. So the mother has not given her any prophylaxis or rescue inhaler during the current illness because she believes that herbal syrup is all that she needed. So huge, huge problem and the clear trigger for our patient. In other history, this child does not have any other remarkable points in the history. She's fully vaccinated as well, which is very important to ask. And the mother is known to have eczema, which is relatively common if you have one kind of allergic propensity in a child. There's a high chance that the family members are also having a different kind of allergy, for example, eczema, asthma, atopic dermatitis, a kind of food allergy. So it's good to know if there's anything like that in the history. So coming to the crucial point, and this case is given in a very academic way, but at the very beginning, you'll look at the child. You'll not be speaking with the mother in a corner, and the child will be desatting and in severe distress, waiting for you to complete your entire history before giving them any medications or intervening. But in an academic format, after the history, we go for a complete examination. We start off with the vital signs always. So we see that the child is having a low grade fever. Saturation is 94% on room air. She is tachypnic and she is tachycardic, and we are referencing this based upon her age, which is 5 years. So these are age appropriate vitals on the right side, and we can see that our patient is above the target for her age. So let's look at this video. I've gotten this from another YouTube video. So it will help us know what a child with an asthma exacerbation looks like, and keep in mind certain points which you're noticing on the child's appearance so that in the coming slide we can see how many you got. Okay, so I hope you were able to hear the sounds as well. But this child was agitated, but she's alert. She's clearly having wheezing. She wasn't on oxygen at the moment. She looks well hydrated, but we obviously have to check her mucous membranes, check her capillary refill to make that statement more confidently. She's having subcostal and suprasternal recessions. And on examination of the chest, you have found bilateral equal air entry with loud wheezing and a prolonged expiratory phase. So this is very classic of a child who's having a lower respiratory tract kind of obstructive picture. So you have narrowing of the airways, and that creates a whistling sound. And why is there prolonged expiration? As we know that inspiration is an active process, but expiration is a passive process. So when you inspire, you're using energy to contract the rib cage muscles and the diaphragm to allow the air to get sucked into the chest. But when you're breathing out, those muscles just relax naturally and the air gets pushed out. But when you're having a kind of lower respiratory tract obstruction, let's say in asthma or in bronchiolitis, so the airways are narrowed, so that process of air going out of the chest takes longer because the airway is narrowed. And just like in any kind of situation, let's say between two buildings in a narrow alleyway, if you have very strong wind blowing, it will create a kind of whistling sound. So the same phenomenon applies to the chest or to the airways in asthma. And in pertinent negatives, she's having a completely normal general physical examination. So now that we've established that she's most likely having an asthma exacerbation, is that enough for us to, manage this patient? Yes and no. So we know what kind of disease she has, but we need to know the severity of the exacerbation. And how do we determine that? So there are three main domains which we are evaluating to get an idea about severity. So symptoms, signs, and functional assessment. So what is symptoms? Symptom is what the patient presents with. A sign is a scientific evaluation which the physician does or the nurse does to determine what the patient is presenting, what kind of presentation the patient has. And functional assessment is by using a tool or a test to determine a certain value. So in symptoms, we are looking at alertness, level of breathlessness, and ability to speak. In signs, we are looking at the heart and respiratory rates, wheezing, use of accessory muscles, cyanosis, pulsus paradoxus. And for functional assessment, we're looking at the oxygen saturation on room air, the blood pressure, the peak expiratory flow, and the partial pressure of oxygen and carbon dioxide, ideally on an arterial blood gas. So we'll look at each of these in details now. If we have a mild exacerbation, what does that mean? It means that the child is having breathlessness on exertion only, but they are comfortable when they are at rest. They can lie down, they can speak in sentences, and they can be a bit agitated. In the signs, they will be having increased respiratory rate with minimal accessory muscle use. They will be having moderate wheezing, pulse less than 100 beats per minute. That means they will not be severely tachycardic, and there will be no pulsus paradoxus. Moreover, the functional assessment will show a peak expiratory flow of more than 70%, normal partial pressure of oxygen and carbon dioxide, normal saturation, and normal blood pressure. So let's have a look at this video.
Notice that wheeze is always heard as the child breathes out, but that the actual character of the wheeze sound can vary from child to child.
Coming to the moderate case, so in a child with moderate asthma, they will have breathlessness at rest. The child will prefer to sit rather than lie down. They will be speaking in phrases rather than sentences, and they are more likely to be agitated. In the signs, they will be having all the signs of respiratory distress as well as tachycardia. And in the functional assessment, the peak flow will be relatively lower, so 40 to 69%. The PO2 will be maintained, but the PCO2 can be lower, showing signs of washing out of PCO2, which happens in tachypnea. And the saturation will also be borderline on room air, so 90 to 95%. Now let's have a look at this video. As we can see, compared to the previous child, this baby is having much more tachypnea. They're having much more marked subcostal recessions, and they seem less comfortable than the previous baby. For cases of severe exacerbation, this child will probably just be sitting upright if they are able to, speaking in words rather than phrases or sentences. They will be agitated, unable to feed or breathe comfortably. They will definitely be having a lot of use of accessory muscles. Loud wheezing, tachycardia, tachypnea, and pulsus paradoxus will be more evident in this case. So a brief touch on pulsus paradoxus. So pulsus paradoxus is a drop in the inspiratory blood pressure on the blood pressure during inspiration. So if it is more than 10 millimeters mercury, this is significant for pulsus paradoxus. On the functional assessment, you will find a peak flow of less than 40%. You will find that the PO2 has dropped now, and this is on an arterial blood gas, because the child will be having poor ventilation, so oxygen will be low, and the PCO2 can start to rise actually because they are having ineffective ventilation. So it's a sign that this child is going towards respiratory failure. The saturation will be less than 90% on room air, but the blood pressure will still be maintained. So as compared to the moderate, we know that severe in the blood gas is showing signs of respiratory failure or starting of respiratory failure. So you're going to have a drop in the oxygen, a rise in the partial pressure of carbon dioxide, drop in the saturation, as well as signs of pulsus paradoxus. So let's look at a video of a severe exacerbation. So in this video, we're clearly able to see this poor baby who's having severe grunting. He's not lying down. He's having a lot of recessions. The monitor is alarming, which probably means either something is wrong with his vital signs. It may be that his saturation is dropping. He's clearly having a chesty kind of sound of mucus and of wheezing. So this is a clinical picture of a child with severe asthma exacerbation. When it comes to subarrest, so this child is basically progressed very far beyond in their asthma. They will be drowsy or confused. They will not be breathing well. So this is the end stage of an exacerbation. When basically the child has been running a marathon this whole time. Every breath has taken energy from them. And if you have left the child for a long time, you will find that they stop breathing well. So they will have poor respiratory effort. The child is exhausted. They are cyanosed. They can have thoracoabdominal breathing, which is an abnormal breathing pattern. The wheeze will be gone because the child can't breathe anymore. So there's no airflow, there's no wheezing sound. The vital signs will all start to drop. They will have bradycardia, hypotension. The oxygen will obviously be very down, carbon dioxide will be quite high, and peak expiratory flow will be less than 25%. So the point of recognizing the stages of asthma is to be very far from this stage when a child is coming to you with their exacerbation. You want to catch the child early and start your intervention rather than prolonging their exercise or the marathon of breathing for them to eventually reach this point.
Subcostal retractions, which are very severe in this child. Also note movement of head during respiration. I meant to say breathing.
So you see that this child is completely almost unconscious. He's unresponsive. He's breathing with much difficulty. He's still able to breathe quite fast with retractions, but if you leave this child further, he will definitely collapse and crash. So this is the absolute end, which we have to avoid in kids. So with all that being said, we come to a formal index or a grading for an asthma exacerbation. We can see here that they're using the respiratory rate, presence of wheezing, inspiratory to expiratory ratio, use of accessory muscles, and oxygen saturation. So if your score is between 7 and 11, this is a moderate exacerbation, and more than 12, it's a severe exacerbation. Let's have a look at our patient's video. So we can see here that our patient is having a respiratory rate of 55, which we had mentioned earlier on in our case. She's having wheezing throughout. She's having prolonged expiration, as we mentioned in the initial slides of the examination. She's definitely having accessory muscle use. And we mentioned that her saturation was between 90 to 95%. She's not dropped below that, hence giving her a score of 10, and she's fitting into the moderate asthma exacerbation criteria. Now that's it for this presentation, guys. We'll move to the treatment in the next presentation, and hope that you